Welcome back to our plenary. So we are now approaching our last session, which will deal with a summary and synthesis of presentations and also with the provision of the perspectives of my German colleagues, Professor Keyvan Bozorgmer from Bielefeld University School of Public Health and Claudia Santos-Höfner from Robert Koch Institute in Berlin, Germany. So you're with us, hopefully, and I would like to give the floor to you now, Keyvan and Claudia, please.
Thank you. I have a technical problem. I'm sorry, but it says I can't, for some reason, I can't start my video. It says that the host has stopped it.
Yeah, okay.
Okay,
I will start it. Just a second. So.
Perfect.
Okay. There is some back noise somewhere. I will just find out. Yeah, I know it's from. Can you hear me?
Yes.
Okay, so now it's better. Yeah.
Okay.
The stage is yours.
Well, thank you.
Okay.
Keyvan, do you want to go ahead? Yeah.
Yeah, thank you very much, everyone. I hope you can hear us. And first, big thanks and very happy to be here. Many thanks to the organizers, Alexander Kremer and the whole team of the Refugee project. It's a pleasure for us to be able to host now this final session after a very enriching day and to be able to reflect and discuss upon the rich ideas of the eminent colleagues and academics who have presented in the preceding sessions. My name is Keyvan Bozorgmer. I'm head of department at the Department of Population Medicine and Health Services Research. Together with Claudia Santos-Höfner from Robert Koch Institute, we had the idea to discuss with you or how to go about now and to discuss what might be some important steps for public health research and action. And we did not really plan now to provide answers, but we wanted to summarize briefly and reflect upon the contribution of the eminent colleagues and thereby raise a couple of questions and to basically, so our recommendation would basically be to an invitation to discuss with us, but then also deal with the question on how to engage more intensively with the questions we raise. So this is what we actually plan now for the next few minutes. Claudia, anything from your side to be added? Or?
Well, yeah, I also want to, before we get started, I want to thank everyone for this wonderful opportunity. This was, to me, a wonderful, two wonderful sessions where I learned a lot. And well, I think Keyvan probably will agree that it will be very challenging to summarize all the rich information that you have given, but we will try our very best. And yeah, we don't want this to be, we really want this to be interactive in a discussion, and we're looking forward to coming into a dialogue with you.
So obviously, one of the observations we faced across all the presentations was that public health research and health research is concerned with morbidity burden and health status of forcibly displaced populations. And I think if we can try to summarize not only this day, but also map the research landscape of refugee health research, we will find that actually a lot of research is usually concerned with health status, health challenges, and morbidity issues, which have commonalities due to the contexts in which people live, but there are also variations between different countries. For example, depending on the regions, there might be specific health challenges being more dominant than others. But at the bottom line, we can actually say that there is barely ever a forced displacement event that comes along with health benefits. So the question is kind of academically and intellectually, how can we move forward from the question of measuring health and disease burden, which is obviously very important from an operational perspective, and to inform policy and practice on what kind of responses and healthcare interventions are needed. But how can we basically push the research and action agenda a bit more forward to probably more structural issues? One of these structural issues is that in very rare, with the exception of very rare situations and countries, usually forced displacement is interlinked with camp and encampment policies and camp contexts and other confined settings like detention centers. The question is also, how can we, if we look now at the different example, camp contexts in Greece, in Turkey, in Pakistan, in Bangladesh, that there is certain commonalities about these, the camp as a phenomenon. And one of these phenomena that we actually can observe is that these contexts put people's social, economic, and cultural rights in a temporary hold. The temporariness that was mentioned by some of the presentations, or the issue that people are trapped in a situation where they are in a kind of human right limbo, waiting for something to happen or for some status to be approved, is paradoxically becoming more and more a permanent status. So we have the situation where temporariness is becoming permanent. And this paradoxon, if you allow me to put this in a more philosophical approach, is can also be regarded as a kind of dialectic from a Hegelian perspective. So how do we go about a situation where an increasing number of people's health and economic and social and cultural rights are increasingly put in a permanent states of exception, for example, to work with terms of other people like, or philosophers like Agamben, who discussed that the exceptions and the permanent states of exceptions created by sovereign national states create policy spaces where the individual is put under the kind of policy influence of sovereign actors and state actors. So one of the questions and challenges would be to deal more with these situations and the question of how can we overcome these situations, which ultimately affect not minorities, but if we look at the bare numbers and the more than, roughly more than 80 million people being displaced, they would make up a country that is among the top 10 or top 20 largest countries by population size. But this population, this large and kind of country population, has no sovereign that deals for its right, but it's depending on single national silos to deal within their political and ideological frames to allow or restrict or permit or deprive them of their rights. So dealing with these permanent states of crisis that shape policies and responses is, in my view, a commonality of the presentations we heard, and also a challenge to deal with academically, to identify windows of opportunity to intervene at more structural levels. So linked to that is the conceptualization, and I thank a lot the colleague Sarah Jabu for his intervention on saying that framing is important. So we also need to reframe the debate from minorities to majorities on a global scale, because a large majority, a large size of the population is being affected by these challenges, and there is no perspective actually that we will have less situations like this. Another area which I found quite interesting, and also as a red thread across the many presentations, was the intersection with different challenges. We heard about the intersection, very pertinent examples from Syria in the intersections between war, conflict, and crisis, but there are more intersections. So how do we go about the intersecting crisis of kind of refugee health and refugee crisis issues linked to conflicts, linked to climate change, linked to ongoing crisis of governance? So we need to focus on the drivers and on the ideologies that lead to these intersections, and also find ways, academically and practically, to deal with these kind of concurrent stages of crisis, which we could also understand as endemics. I'm not sure how many of you are aware of the terms endemics, referring to exactly these type of intersecting crises that reinforce and cause each other, or where one crisis is the effect but can also be a cause of the other crisis. And I would say that our methodological approaches and conceptual approaches to analyze these interrelations are yet quite at their infancy. So there might be some interesting works out there, but the majority of the work does look at refugee health issues usually in a silo, in a political or political isolation, as being detached from many other crises. So here is an opportunity and an important area to push the agenda forward. And the third and final point, in my view, is also linked to the issue of intersection, to understand better the question of how we can deal with the protection and the granting of economic and social cultural rights as an issue of a global public good, and whose provision, so the provision of these public goods, similar to other public goods that we observe, for example, now in the COVID crisis. Claudia will elaborate a bit more on this, but on the COVID-19 ideally exactly shows us how many challenges we face in the provision of global public goods. For example, when it comes to generating vaccines and sharing them as they fairly and equitably across the globe or across a set of countries. This is very much different from the setting of refugees at the first glance, but the underlying problem that is common to COVID-19 interventions and vaccine issues, and, for example, granting the right to protection, fulfilling the human right to health, is the same issue of that we have no structures, no governance mechanisms that allow cross-national insurance and production of global public goods. So the question is what is the contribution that public health academics and public health practitioners can make to these three different areas, ranging from encampment to the analysis of multiple concurrent and intersecting crises, to the challenge of producing global public goods in different areas, but especially in the area of refugee health. So with this, I would hand over to Claudia to add to these reflections.
Thank you. Thank you so much, Keivan. I think you already mentioned quite a few things, and I feel like we could probably discuss for a few hours just the questions that you outlined. I want to elaborate a little bit more on COVID-19 as an example that shows us right now where the roots of the problem, of some of the problems at least, lie, because we see in refugee health and in migrant health and in health care and equal access to healthcare overall, because we've seen now in the last 9 months quite a development, and I think this is COVID-19 gives us an opportunity to look. Usually it always takes us a while to generate data, to analyze it, and to come to conclusions. And here we see very, very quickly a development that is going that is showing us again inequality in health and access to healthcare. So, but before I start with this, I want to add that exactly those factors of insecurity and uncertainty were mentioned a lot in a lot of the presentations. Insecurity in terms of like not necessarily having access to basic needs, and uncertainty. And I think, Kevin, you already highlighted that, not knowing what is going to happen. And this, of course, has even gotten worse with the COVID-19 crisis, because it means partially that in certain living situations, people are being put into quarantine. People don't know why. They don't know what is happening. And so this is really, really important, I think, to look at COVID-19. Charles already gave a very good overview, and he already mentioned that it's an example to look at what's happening in a magnifying glass. We see, especially in Europe and in the US already, but also in other places, that especially ethnic minorities are affected more often and more severely by COVID-19. And there are a lot of potential reasons for that. And the main reason seems to be inequality. And when we look at this a little bit more deeply, it is, of course, precarious working conditions, precarious living conditions, and living situations that make people particularly exposed and vulnerable to COVID-19, as well as not having access to healthcare. And when we look at these factors, these are all factors that are given, or that are basically were mentioned in a lot of the presentations and examples from the different countries, how refugee health was being described, that exactly we see a lot of precarious living and working conditions, and people thus are exposed to all kinds of different conditions, but also to COVID-19. And when we look at COVID-19, we also see something else. We see not just in inequality in terms of like the poor have less resources, less access, and are more exposed, but we also see structural racism and racism towards people who live in certain conditions, because we saw this, for example, here in Germany, when migrant workers who were working in the meat industry were more often there was a big outbreak with a lot of people contracting COVID-19, and they were being put into quarantine, and there was basically a fence around the buildings showing again, and people perceived that, and it was as racism and discrimination against people who are being particularly exposed and particularly vulnerable. And I think this shows our ethical responsibility, again, to act on this and show the causes that are lying underneath the surface. So this is, of course, when we look at hospitalization, disease outcomes, and potentially also what is going to happen with long-term effects of COVID-19. But Kevin already mentioned it. When we look at the possibility of vaccination and the distribution of vaccination among, first of all, within a country, but also, of course, internationally, this poses big challenges. We see, for once, when we look, for instance, in Germany, I mean, there are vaccination plans, but we know that some of the particular vulnerable populations, like homeless populations, and also people without a legal status, will not have access to vaccination, even though not immediately, even though it would be necessary. And we also see that yeah, there's a global responsibility, of course, to provide vaccination for all countries. But whether this is going to happen, this is still under discussion. And I think this is also our responsibility as researchers to hear, raise our voices and try to show this as an example for distributing resources equally and really also providing the facts and information that is needed to prove that it is important to act here. So if we, and I think we all do, if we consider health as a human right, and we really want to change access to healthcare and want to enable access to healthcare for all, I think we have to ask ourselves a few questions. And one of them is, so who do we have to, as researchers, who should we start working with to really tackle this problem? I think, Kevan, you already mentioned, of course, we have to push research into action, but how do we exactly do this? Who are our collaborators? Who can we work with? And how do we work intersectoral with an open understanding for each other's discipline? How can we accomplish this? And also, we are doing a lot of research about populations. And I think it is crucial to also hear the voices of the people who are particularly vulnerable and trying to really engage them into the research. And I think this is something where in a lot of examples, we can still work in. And there is, of course, the question, how can we do that? And how is it possible to really enable to hear these voices and to represent people, not just by talking about them, but by talking with them? And I want to end with something that Samar Jabour said. Well, this is a case to go together. And I think you are perfectly right about this. This is really refugee health in general, looking at COVID-19 as an example to demonstrate it in particular. This is a case where we can go together, and I'm looking forward to a discussion with you now.
Thank you, Claudia, for this very comprehensive and detailed, but also to the point comment and reflection. So, with these brief inputs, we would like to open the floor for more, from questions and comments from the audience that you might want to address to our direction, or also to the previous speakers. So, would now open the floor for your thoughts and reflections.
Maybe I can start, if I may. I still have two questions from the audience. There's one question to Professor Takian. How do Afghan refugees in Iran access education and employment opportunities? Is it the same as the health provision? And what is the situation between Afghan and people and the host community in Iran?
Thank you very much for the important question. Can you hear me well?
Yes, we do.
Yes.
Okay. In terms of the educational opportunities, up to 5 years ago, Afghan refugees had some restrictions. One of the main problems that I mentioned in my presentation is for each legal Afghan refugee, we have 2.5 more people who are illegal refugees. So in the course of last 4 decades, the government has been debating so much whether we should recognize these Afghan refugees who are undocumented, because if we do so, then we will have encouragement for more Afghan people to come to Iran without the situation. So that's why, but eventually what happened was in 2014, the Supreme Leader decreed that all Afghan refugees, irrespective of their status, they can have access to education. So free education for those refugees is being provided now, and they can continue up to the university, a specialty and things. But the difference is for the university, they are considered as foreign students and they have to pay. But for other aspects of the education, if they are legal and documented, they will have access for free education like others, like they have access to care. But in terms of employment, what has been happening in the course of last 2 years is somehow very unusual, because after the United States sanctions against Iran, the inflation rate was really high, and the currency exchange was really high as well. So the Iranian currency lost its value very much. So many Afghan refugees had the advantage of going to other countries and going back to the home countries. That's why in terms of employment, now the Iranian market, we are really looking forward for more workers from Afghanistan to do so. But beforehand, they had been occupying lots of construction industry in Iran. Many of them who were legal, who could apply for job and they could have job. They had a kind of document which is called Amayesh card in Farsi, which is like the residency permission, so they could apply for any job. Of course, in terms of employment, some of them were less than Iranians, that's the reality. But in some particular employments and jobs, Afghan refugees were at the top, specifically in the constructions and some of the labor in the industry. I hope I have covered both dimensions of the question. Over.
Yes, I would have another question from the audience, if that's
go ahead.
Okay, to Professor Chapeau this time. Thank you for your presentation. How do you see the situation of Syrian refugees in Lebanon in comparison to Palestinian refugees who are there since 1948? Are there any comparative studies maybe on that?
Thank you very much for the question. There have been several studies, including one carried out by our colleague here at AUB, that looked at not just Palestinian refugees and Syrian refugees in comparison, but looked at an in-between category, which is the PRS, the Palestinian refugees from Syria. As you know, quite a few Palestinian refugees from Syria were displaced because of the conflict to Lebanon, some also to Jordan. It's hard for me to remember all the details of the comparisons, but the PRS, the Palestinian refugees from Syria, tend to do quite poorly. The refugee experience, however, from Syria and Lebanon, whether it's PRS or Syrian themselves, is really variable depending on the area, the time of the the dates of the displacement, which year, the context of the displacement, where they got displaced to, and the experiences over time. So, and it also has gender dimensions. For example, we do see that young women and girls and young women really shouldering terrible pain. In the Beqa, you will see refugee women working up the field for 10,000 liras a day. That's the equivalent now, after the collapse of the pound here in Lebanon, equivalent to less than $1.50. But of that, their intermediaries take 40% cut. So it's really in some of those experiences account to unbearable forms of exploitation. Over.
Thank you very much, Samer. I have further questions here from the audience. I think this question, the first one, goes to Samer Jabour, but can also go to Dr. Khan and Rubina Zakar. Can you please tell us about your experience in accessing or collecting data for healthcare research in conflict zones?
I must say that that this is the answer to this is an evolving question. So if you look at the duration of the various conflicts that are now active, you will see really an evolution in the methods used, in the ability to access data, in the ability to access key informants over time. For example, in the conflict that I study most intensely, in the Syrian conflict, data collectors have themselves become far more sophisticated over the years of the conflict, which has now become protracted. And researchers have adjusted to lack of access to populations inside Syria because of security issues through adapting geospatial methods and all of that. There are now use of innovative techniques, for example, WhatsApp to document attacks on healthcare. So there are really many methods that now are in place to collect data. Health services data has become much better compared with a few years ago. Right now, as of 2018, many groups in the northeast and the northwest of the country are actually implementing the DHIS2. So things are evolving, things are better now, but the conflict intensity has also been reduced over the past year. Over.
Thank you very much.
I want to share my,
Yes, go ahead.
I want to share my experience of working in such conflict areas because we last year we were working on evaluation of maternal and child health week, and we have to study it, evaluate the program all over Pakistan. So this area, the Waziristan, if you have heard about the area of Waziristan, because it's the area which is included in KPK, Khyber Pakhtunkhwa, and it is earlier it was considered as FATA, federally administered tribal area, because this is a tribal area, so it is very, very difficult, and most of the time there are activities going on related to war against terrorism. And a huge population is Pashtun. So it's very difficult to reach in this area and to collect data related to on different health issues, particularly related to women. So last time when we went there, so we had experienced a lot of problems, and they did not allow even we have engaged local high influentials to get data related to maternal and child health related indicators. But families they did not allow us to go to the area. At the first point, we received the hindrance at the different checkpoints where they could not allow us earlier to go into the area. And then when we showed the permission for 2 or 3 hours after 2 or 3 hours they allowed us. And when we reached in the community, we had experienced a lot of resistance. So it is very, very difficult to work in areas, especially in traditional tribal areas in Pakistan. And so that's why you will see that we don't have authentic data available from these areas, because most of the time when we are conducting research, only we have very little data, and we have to generalize this data on a small data on a big population. So this is the problem which we are experiencing. And similarly is the case with respect to refugee health. And I'm very thankful to Professor Kramer, because in Pakistan, there's not a lot of researches available on refugee health, specifically on Afghan refugees. And now one of my students, he's working on mental health status of Afghan refugees. And Professor Kramer, I'm very thankful to him. He is helping him in this research. And similarly, one of our student, she's working on oral health of Afghan refugees. And so now more and more students, they are interested to work on refugee health on different dimensions. Because one of the big problems that we are experiencing, it is related to authentic data, which would be nationally representative. Because in Pakistan, we have only one database which is available. It's Pakistan Demographic and Health Survey, where we can get nationally representative data. So because even when we talk about Pakistan and other indicators related to Pakistani population, we don't have much information available related to different indicators. And when you talk about the refugee health, so you can imagine that data is totally missing. So there is a lot of, there's need to work on such topics. And I think we need a lot of collaboration to work on refugee health. And first we need to provide some evidence that what kind of problems they are experiencing and how we can solve these problems. So because when for the last 40 years, refugees, they are living in Pakistan, they are going back, and some of them, they are coming back to Pakistan. So, but we could not do a lot for them, which should be within the perspective of health and human rights. So they are, that's why they did not become the productive member of our society. So if we empower people, then we can get benefit. And in Pakistan, there is a huge need that we have to empower our refugee population. Thank you so much.
Thank you, Rubina. And maybe also Professor Khan, a small answer to this question, if you wish.
Yes, I can say something regarding this. Actually, data collection in the conflict area is not very easy. There is a lot of resistance already because, you know, these people are interviewed very frequently. At the beginning, they were not very reactive, but nowadays, if you want to collect data from them, it becomes difficult. Also, before going for data collection from this area, you need permission from the designated authority decided by the government. Without permission, actually, you cannot go for any research. You have to submit your document so that you can get consent for permission. Also, other issues, if it is a research project funded by some grant or authorities, then you have to submit your proposal for ethical clearance, and ethical committee actually check everything. Normally this committee is formed by different people coming from government and non-government organizations, so they checked everything according to the guidelines of the government. So actually, what I want to say, as compared to other parts of Bangladesh, maybe data collection in this area is a little bit difficult and challenging.
Thank you, Dr. Khan. And I have another question here from the audience that could go to Claudia Höfener. So the question would be how migrants experience healthcare services, like an information letter of the local authorities, for example, in Germany or in another language, and how can insecurities with respect, for example, to misunderstandings of vaccines be reduced, not only with respect to COVID-19, where the vaccination period is now starting, but also, and this goes also to Muslim countries, for example, because there's a big opposition against this, for example, against polio. Would you like to take the floor, Claudia, to answer this a little bit?
Sure. I mean, okay. Can you hear me? Yeah.
Yes.
Yeah. If I understand it correctly, the first question is about being notified by the health authority about quarantine or isolation. Is that the first part of the question when regarding COVID-19? Well, that is definitely an issue if people because most of the notifications, sometimes people are being called, sometimes notifications come first by mail. And if they are only in German, if someone doesn't understand the letter, that is definitely an issue. I think that is handled very differently from local health authority to health authority. I know that in some of the contact tracing places like in Berlin, that they do have partially bilingual staff who will try to contact people who do not understand a letter or who are known to have like a different a non-German nationality. So that happens partially, but not all the time. And that is definitely something that might cause insecurity. If I receive a letter, I do not really understand it. And I know I don't necessarily have all the information that is required. I think what's important here, and that's also with the examples I mentioned about precarious working situations in COVID-19. Here it's important to work with first, of course, interpreters, but also cultural mediators who will explain the situation in a sensitive way and in the language that is required. That is really important, because otherwise all these restrictions and also whether it's fences or other arts of isolation, they cause fear and misunderstandings. And so I think most important is to really try to find interpreters, to work with NGOs that can provide interpreters and cultural mediators and have connections with the community. And in terms of like vaccinations and potential attitudes or fear of vaccination or not wanting to be vaccinated, I think that is something. There was a project at RKI a few years back where we looked at vaccinations and how vaccinations are being perceived in different migrant communities. And it showed that, again, one of the issues was that there was not enough information in the respective languages, and that people did not know why they should do this and why it's so important, partially. And so, again, I think that can be very helpful to first of all train doctors and being sensitive and trying to really explain the situation, and then providing materials in different languages. But then if there is more to that, I think this needs more research, and we should try to understand what are the barriers in getting vaccinated and what is the root of the problem again. And here we need to talk to people and do either a survey or potentially speak with people from the community to better understand this issue.
Thank you very much, Claudia. And I have a last question that is very important also, again from Adama Tordi, that has posed various questions before. And I would like to address this question to Keyvan Bozorg there, if I may. So she's commenting that current policies in research only focus generating data and produce knowledge, but how can recommendations be implemented? How can we go forward? So Keyvan, in your very thoughtful comment synthesizing our session today, you have been talking about the even dialectic philosophical perspective and also health policy perspectives, talking about intersections. Would you like to say something about these questions?
Yes, sure. Thank you very much for the question. I think this is an important question, and it raises or touches upon the issue that Claudia raised, that we actually need to understand who are actually our allies and partners, and what is the kind of actor institution environment in which we want to implement things. We usually tend to things in our kind of healthcare silos, but once it comes to the more structural policies, we very much are depending on a better understanding to know who our allies and partners are. To give you an example what that means, it touches upon the issues of implementation, research, and in this context, we really need to understand what is behind the motivation and the drivers, or the rationale behind people acting the way they do. We have, for example, situation where, from our own research, where we observe that, for example, policy is implemented, for example, quarantine among refugee centers, and when we then try to better understand what was actually the rationale behind the decision to act like it happened, we realized that sometimes those people where we thought that these are actually our allies because they come from the public health authorities, and there are other kind of migration authorities who we assume might be more restrictive, and maybe the order came from this sector, is completely wrong. And we realize, no, it's actually completely the other way around, and that there are dynamics, also power dynamics behind the mandates and the local structures that lead to a certain measure being implemented. And I think in this direction, we are very much, I think there are locally and also, well, in different areas, a lot of good ideas on how to improve healthcare, improve the performance and the responses. But we are not always very good in analyzing how we can implement things. And I think in this area, we need to build much more on implementation research approaches, and also on approaches that look at these issues of understanding the local systems being set up of individuals and agencies with different power relations. Understanding of that will help us actually to navigate through these different tensions and synergies that can be built when we want to implement things.
Thank you, Keivan. This is a very nice final perspective that you provided. And as far as I cannot see any further questions at the moment, yes, I would only like to say a few words of thanks for the last two moderators, and also certainly again to all the speakers, to the participants, the discussants, especially also to Dr. Kerstin Schmidt for providing a lot of organizational support and moderating the second session, and particularly also to Miriam Simon from Concentris and the TIL team from Bielefeld University for the great organization, Miriam, especially for the great communication with all the different speakers and with the audience. This was fantastic. It worked very well. And also the TIL team that you brought on board also for the technical support, that also the technique worked very well. And okay, so it was a long day, and thank everybody for sticking so long with us. And I truly hope that I will meet some of you in the near future also physically. So I would like to say goodbye to you, and thanks again. Wiedersehen.
So
Tschüss.
Thank you, Dr. Marcus.
Bye.
Thank you. Bye-bye.
Very much.
Thanks, everyone.
Take care.
Thank you. Bye-bye.
Bye. Bye.